right, you all. I realize I'm the last one between the hospital and happy hour for you all, and I'm just as tired as you all. So I'll go through this. I promise we'll make it as entertaining as possible, but I think there'll be helpful hints just for the general care of a pediatric orthopedic patient, no matter what unit you're going to be working in. So feel free, it's pretty informal. Feel free to stop me if you have any questions along the way. I talk pretty fast, so I have a million slides here. We're going to go through a lot of information, but I will point out the really key things that would be important for you all to know. I have nothing to disclose. So we'll talk about some basic fracture management, open fractures, and some of our most common fractures that require surgery. So these patients will travel from the emergency room to the OR and sometimes up to the inpatient units with elbow fractures. And compartment syndrome, of course, is the one thing you really need to be familiar with identifying. So childhood injury is the leading cause of death and disability. And about 25% of children, believe it or not, will have some injury in the span of a year. And a good portion of those, up to a quarter, are actually fractures. So we see a lot of injuries. This is our heavy trauma season. So we are kind of still like weaning down from our peak orthopedic trauma, probably general trauma as well. The weather is nice. Football is happening, and kids are at school and at home. Kids can hurt themselves pretty much anywhere, so the home environment actually is a little bit more common than at school, but we see a lot of fractures from all sorts of recreational activities, parks, and of course, higher speed energy, and even some penetrating trauma that we will see at this hospital. Kids are pretty unique, so I'd like to give you a little bit of background about what the bone anatomy is like for a child compared to adults. There are 4 different areas of bones, and that leads to distinct injury patterns that can happen at different levels. So the epiphysis describes the areas near the joint, and then children have growth plates called the physis, and there's a growth plate at the top and the bottom of every bone in the body that can be susceptible to injury. The metaphysis is the area just underneath the joint, and the diaphysis, think about the long sort of portion of the bone. And kids are pretty resilient. The bones are more resilient to stress than adults. So they have this big sort of a force is sustained to the extremity. And there's a big area, what we call plastic deformation. So sometimes the bone can bend just like this before it even fractures. So we treat kids sometimes differently than adults. They also have a thicker, what we call periosteum. So that's like the banana peel or the thick rind around the bone, and that kind of helps support the bone as well. So even though a bone may look pretty angulated or deformed upon arrival right after the injury, there's a good chance that we can get that bone properly aligned and placed into a cast, because there's a lot of thick, strong vascular periosteum that helps with the healing, but also helps stabilize the bone so that we can manage most of these with casting. When a bone breaks, there's a big inflammatory cascade that happens in the body. It bleeds naturally, and the blood sort of recruits all of these cells that are necessary to heal the ends of the fracture. The very first thing that happens is a lot of cartilage is laid down. We call that a soft callus. Callus is the healing bone, and then over time that cartilage turns into bone, and it becomes the hard callus, which we technically would say something is healed. And then kids have this other amazing feature called bone remodeling, and that's over time as the child grows and they're continuing this repair process after a fracture, the bone will actually start to strengthen and reorient itself. The cells will stack themselves back up so that bone can go back to withstanding the same force it's meant to withstand in the body. So remodeling is unique, obviously, to younger patients. It's sort of the longest phase that can happen months or even years after a fracture has happened. And what that means is that kids' bones don't have to be perfect. So when we put them in a cast or fix them with surgery, it's not necessary to have the bone 100% lined up. So the younger the patient is, the closer the injury is to the growth center, the physis in the bone, we can accept more angulation or more abnormality, because over time, as this process of remodeling happens, the bones will gradually straighten themselves out. So Mother Nature takes care of itself. This is a pretty cool example. Sometimes when a child comes in and they've broken both of their bones near the wrist, and if we just line it up in a cast like this, and the parents are horrified because they say this bone is not going to heal, those bones are side by side, they're not lined up properly, but it will heal. That's the callus, all the new bone mending the two ends together. And in 6 months, it looks like nothing ever happened. So that's the beauty of kids. So do we treat all fractures the same? Absolutely not. There's lots of general principles that we have to apply. But most fractures in kids can be managed non-operatively. So the vast majority of kids who come in with closed fractures or stable fracture patterns can be managed non-operatively, typically with some type of immobilization, cast, splint, brace. The initial treatment is generally the same with any fracture. You want to provide some sort of temporary splint for comfort and also to add some stability. And then many kids may need some type of manipulation or what we call a reduction, which is a realignment maneuver to get the bone in acceptable alignment with the cast. So when in doubt, if this is something that could be splinted and it could be sent out from the emergency department, or does it require some more special techniques, when in doubt, obviously call orthopedics. So there's been a little bit of philosophy change, but I still like to remind everybody that children are not mini adults. They still have better healing. They have more potential to go through that remodeling process and straighten things that are not straight at the time of healing. There's a little bit of pendulum shift sometimes towards a little bit more operative management in kids, but still remember that the vast majority of these injuries can be cared for non-operatively. So a lot of people are very afraid of the orthopedic examination. It's not like listening to the heart or listening to the lungs or something that you do very repetitively in your training or your practice. But if you follow the same principles of your examination like you do when you are listening to the heart or listening to the lungs, then you can kind of break it down and it can be pretty easy. And the first thing that you're going to do is just examine them and look at the patient. And then once the injury has been identified, of course, some sort of temporary immobilization. The kids need proper imaging. Usually these injuries can come along with a lot of swelling, so the extremity should be elevated right away, whether it's in the emergency department or post-operatively in the recovery unit. They need adequate pain control. They need adequate pain control just to be splinted, just to get an x-ray. And the key is really to do no harm, right? We want to prevent any additional complications. And you'll learn here that just about everything can cause a complication. So the clinical examination, step number one, look at the patient. Is there a gross deformity? Is it the arm? Is it the leg? Is there a lot of swelling? Is there a lot of bruising? Are there any open wounds that can indicate that fracture penetrated the skin and communicated with the external environment, higher risk of infection? Palpate where the patient is tender if there's not any obvious swelling or deformity. And then you have to have some sense of what kind of neurologic examination you're looking for. So you're looking for active movement. Can the patient move the fingers, the toes, the ankle? Do they seem to be sensate everywhere that you're touching them? And then, of course, a good vascular examination. We all know how to check pulses, so we want to make sure that there's good brisk capillary refill distal wherever you think the injury may be, or that you can feel pulses, so you can communicate all of these things. And then also get a sense of urgency. And then documenting what you see, because in many kids, the swelling progresses, especially if they're sitting in the emergency room, like we have had the experience for 12 hours or more. Without the extremity elevated, there can be a lot of swelling that happens overnight or over a period of time. They can start to have nerve deficits, so things can change. So it's very important to know what we started with so we can know if things are evolving in a more urgent direction that would require more immediate care. The goal of any type of immobilization is, number one, comfort, right? We want to make sure that the kid has good pain control. It can help align the bone or prevent what we call loss of reduction or loss of proper or acceptable alignment for the bone to heal. And it also just calms the inflammation, so the tissues aren't sort of moving around trying to stabilize the bone. It calms the muscles, calms the pain, calms the bleeding. And that can be with a variety of things, a cast like you see here, a splint, or some type of brace. But beware that an improperly applied splint cast brace can lead to major problems, skin breakdown, ulcerations. Lack of padding and skin ulcerations is one of the biggest culprit of a poorly applied splint or cast, and we see this time and time again. So everything can cause a complication, even a simple splint that's placed on a child in the emergency room for later follow-up. An Ace Bandage, I say the dreaded Ace Bandage because we see problems all of the time with these. They can cause skin abrasions, simple things. They can cause swelling if it's wrapped too tight around the wrist and all the way up the arm. The whole hand can be swollen. And it can cause ischemia. And I'd probably say once a year, just this past weekend, we had a child lose a digit because of something that was too tightly wrapped around around the fingers. And he now has an amputation, and it happens probably once a year. There's circulation that's cut off from a bandage that's tightly applied. So always remember, everything you do can cause a complication, even a tightly applied Ace Bandage dressing, cast, splint. So beware, these things can really be problematic. So these are simple skin abrasions from real patients that have occurred from swelling that develops over, 48 to 72 hours after the splint is placed on. Even if you think the Ace Bandage may not be too tight, if there's not enough padding between the skin and the bandage, then it can cause a lot of skin issues. You can see her hand's very swollen. Again, that's from it being too tightly applied. This is a finger that has some necrosis at the distal tip of the finger, again from either a bandage, Coban, Ace Bandage, something that was too tight on the finger. And these can cause lots of problems. So definitely not to take lightly. The cast alone can cause complications as well. You can get compartment syndrome from a very tightly applied cast. They don't really expand after you put them on once the cast dries. Thermal injury, which is a burn injury essentially, and that's typically from removing the cast. So we can have cast saw burns. The cast saw needs to be used by a trained professional who knows how to safely cut through the cast and not burn the child. And I always say that there are no hypochondriacs in a cast. If the child is complaining in the cast, always best to sort of check to make sure that there isn't something wrong, either by removing the cast, making a hole or window in the cast to inspect the skin, because they can be lots of problems, especially in a child who can't communicate, either a child who's intubated and sedated in the intensive care unit, child with autism or some other communication disorder, or if they have some developmental delays, or if they have impaired sensation, like a spina bifida patient or a paraplegic, for instance. They're not going to be able to tell you that their heel hurts in the cast. So those patients we have to pay extra special attention to make sure that we're doing everything that we can to offload any pressure points in a cast to reduce their risk of having a complication. So this is sort of an example of how to elevate like a lower extremity cast. I always use the term float the heel. So if you ever see a nursing order that says float the heel, elevate and float the heel, that means just that you should place the pillows or blankets underneath the lower portion of the leg that allow the heel to be suspended in the air so that that heel is not in direct contact with something, because that's the biggest area where we tend to see pressure ulcers from casts. So floating the heels, elevation, those are all like nice techniques to do your best to reduce the risk of a problem. I'm not going to go through this that much because most of you are not going to be removing casts independently on your own. You're going to rely on our orthopedic colleagues for that. But there are some things that can be more susceptible to burning a patient, like if the water is too warm when the caster is, or when the plaster or the cast material is applied. The thicker the cast, we worry a little bit more about that coming off, or the less padding between the skin and the cast. So we have techniques to sort of safely remove that, but don't try to do it on your own. Cast saw burns are real. So we encourage most of our residents in the emergency department, if they do need to split or cut a cast because we're concerned about swelling that may happen over the next couple of days, and we don't want the patient to be coming back to our overburdened emergency room because of swelling in the cast, we always encourage them to make sure they're fully awake from the sedation. And if you catch a resident trying to use the cast on a patient who's totally sedated in the emergency department, just point it out to them. So remember, we want to make sure that the child's awake, because the child will tell you, hey, that cast is getting too hot, and then they can kind of stop, slow down, and do some techniques to help with that. But these are also real problems. So the next thing we said in the order of assessment is that we need some imaging. We need to know what it is that we're dealing with so we know how we're going to treat the patient. But the patient needs to be comfortable before they go to radiology to get imaging. They're already freaking out, they've got a bad injury, and then somebody's going to take them and try to manipulate the arm and try to get multiple different x-rays. But our x-rays are critical. This is an example of a patient that was seen at another hospital, and we always need more than one view of the bone that we're looking at. So this x-ray was read by a radiologist at the outside hospital saying it was a minimally displaced elbow fracture. So that emergency room thought that splinting and sending the child up for follow-up with orthopedics would be appropriate, and they didn't get any more imaging, probably because the child was in pain and screaming and couldn't tolerate being manipulated. But, you know, when you get the side view, you can see that that's a completely displaced elbow fracture that's at high risk for compartment syndrome, vascular injury, nerve injury, and really shouldn't be sent home to follow up with an orthopedist a week later. That really just needed surgery sooner rather than later. So good pain control, get the adequate assessment, the adequate imaging we need so that we can determine what's best for the child. And then the elevation. We don't have any of these fancy devices in our hospital, but it's nice illustrations of really how to elevate an extremity. So a river flowing downhill is sort of a nice way to look at it. For the upper extremity, I generally say Statue of Liberty or an incline. So the hand higher than the elbow higher than the shoulder, everything heart level or above. Pillows, blankets, whatever we have. And same thing for the extremity. The ankle should be a little above the knee should be a little bit above the hip, and everything should be heart level or above. So nice elevation, and that can start right away while a child's waiting to be evaluated after an injury, because it doesn't take long to get significantly swollen from some of these injuries. So if many kids are treated in casts, then who is treated surgically? So certainly there are some pretty clear indications of when we might take a child to the operating room to fix a fracture. Open fractures, that's when the fracture pokes through the skin and communicates with the environment, because there's a risk of infection. In many cases, we'll be taking them to clean out the bone and then sometimes stabilize the fracture, since they can tend to be a little bit more unstable than the ones that don't poke through the skin. If the fracture is not lined up properly, or if the bone is significantly displaced and there's no way to line it up in a cast, or if a child has multiple injuries. So that's another reason to fix things, just so that we can get the child up and mobilize them a little bit better, maybe put weight on the extremity a little bit sooner. So multiple injuries is another reason we might choose to do surgery as opposed to a cast. So the next part of the talk is just going to be about some of the common things that we see, and again, that you may see through the different units of the hospital, because many of these patients will be cared for starting in the emergency room and then through the operating room, recovery rooms, and up to the inpatient units or even the intensive care units. So open fractures, we said these are what patients that are likely to go to the operating room. Really depends on how big the wound is, the size of the wound, how dirty it is, if it's a clean wound or if it is, you know, a contaminated wound from a lawnmower injury or something, and whether or not they have a nerve or vascular injury. And there's different sort of classifications or grades. This isn't something that you all need to know, but it basically, you know, goes from a type 1 to a type 3, type 3 being sort of the worst with more soft tissue injury, bigger lacerations, potential for vascular problems or significant contamination. In some cases, the really tiny open wounds, sometimes we can still treat that non-operatively in a cast just with a little antibiotic treatment, because again, kids that have such a great blood supply to their bone, their risk of having an infection following a clean, sort of really small open wound after a fracture would be pretty minimal. But obviously the type 3s are much more significant injuries. But even in children, the functional results after recovering from something like this are much, much better in kids. This is one of my patients who had a propeller injury and was missing part of the bones, probably floating around somewhere in the Potomac River, and this kid's playing basketball less than a year later after the injury. So always assume a full recovery in children. They generally are going to recover much better. But obviously the higher grade of injury, the higher risk of infection, the higher risk that the bones may not heal, or that there could be a potential for an amputation as the most functional outcome if any of those other severe sequelae happen from the injury itself. So again, for our open fractures, I'm only sort of bringing this up, not that you need to kind of understand the orthopedic literature, but to know in our hospital, the time to antibiotics is probably the most important thing to reduce the risk of infection, even for these really tiny open wounds. So if you see any open wound over a deformed arm or a deformed leg, or if we have confirmation that there's a fracture and a wound there, obviously orthopedics is going to be consulted to assess, but our goal is to get the antibiotics in within 1 hour of arrival, preferably within 1 hour of the time of injury. And then the timing of us doing any type of surgical debridement or treatment is a little bit less important than the actual delivery of the first dose of the antibiotics. So most of these kids will be going to the operating room within 24 hours. Obviously, something more extensive that's grossly contaminated might require like more immediate operative debridement to start cleaning out all the potential sources of contamination. And then we'll do some type of fracture stabilization. And open fractures are when we get to be really creative, I say. We had to do something to be able to protect the soft tissues, to promote healing of the bone, and that can be any type of pins, plates, screws, rods that go on the inside of the bone, or in many cases where we have these really bad, ugly wounds, like you just saw in the picture, this is the same patient with an external fixator on the extremity. So that allows access to a wound vac, so nursing can do wound vac changes or wound care, or we can assess the swelling. So there's lots of different ways, and that external fixator can be definitive treatment. It's stabilizing the bone, holding the ankle in alignment until things are healed enough that it can be removed. So that's what we do on our standpoint. Same thing, external fixators are really excellent for cases like this. It doesn't take a radiologist to see that that bone is not normal and it's sticking out of the skin. And this is a picture of the wound that sort of developed and progressed from some local soft tissue ischemia over a course of a week. But the external fixator was great because it allowed the wound care team and the wound care nurses to get in there and manage the skin so that it could heal and ultimately get care with our plastic surgery team. We use a lot of wound vacs in some of these open wounds that might require a return trip to the operating room for repeat debridements. I think it's very helpful for decreasing the rate of deep infections, but it also helps promote some vascular supply so that we can either decrease the overall swelling and later close the wounds, or have our plastic surgeons help us out with some type of skin coverage procedure. So you'll see a lot of wound vacs on our orthopedic trauma patients. Any questions so far? If not, then I'm going to move on with our next, probably most common fracture that we treat here at the hospital. So elbow fractures, we're still in elbow fracture season, which is kind of spring, summer, and fall, but we see them all year round. Very, very common elbow injuries in children. I bring it up because, again, this is going to be a common fracture that you're going to see in the emergency room and through all units of the hospital. But they can also be pretty scary when you look at them. The skin can be pretty beat up, as you see here, and that's because the bone displaces. Many of these patients will come and present either with some type of nerve deficit. I would say 10% is probably a little bit on the lower end. Most of these kids will have some type of nerve injury when they present, or sometimes even vascular compromise. So sometimes the bone is so displaced, the artery and the median nerve are running right across that fracture spike. And so sometimes the patients will present like they don't have good blood flow at all. Obviously, that's an emergency if they have any signs of ischemia of the hand, or with some signs that there is some sort of vascular trauma or injury and might require more immediate attention. Our treatment goals are to get the bone aligned, so that's pretty easy. We want to get it stable, so typically these are operative injuries that we are placing pins to hold the bone while they heal. And then obviously we want to maintain the vascularity of the hand, so the key is always that the hand is well perfused. And we don't want any long-term consequence or sequelae of any type of tissue ischemia from lack of blood flow to the forearm so that the patient has loss of function or contractures like you can see in this picture, which would be something called a Volkmann's ischemic contracture, either after an ischemic injury from no blood supply or from a compartment syndrome that can develop after these injuries as well. Both things can happen. So I said a lot of these patients will actually come in with a vascular injury. The bone is displaced. It's not typically that it lacerates the artery or lacerates the nerve, but it usually just sort of stretches the tissue over the nerve. And so sometimes you may not be able to feel a pulse for these patients. That's a need for a more urgent orthopedics consult. We may be taking those patients to the operating room overnight as opposed to maybe waiting until the next morning. But the key thing on the physical examination for us is whether or not the hand has good perfusion or not. So if the hand is white and you can't feel a pulse, that's even a more emergent situation than if the hand is nice and pink and warm, which means the blood flow is still getting through the muscles of the forearm and into the hand. Even if you can't feel a pulse, that's a much different situation. The reason for that is because there's a lot of rich collateral blood flow around the elbow. So even if the brachial artery is in spasm or has some type of injury and the brachial artery is injured by the elbow, oftentimes the rest of the blood flow support around the elbow will still be enough to give good perfusion to the muscles of the forearm and the hand, which is most important. But step number one, either way, we have an x-ray like this, a child like this that's swollen. Step number one is that we're going to fix the fracture. Our question for us to decide is how urgently this child needs to go. So we're going to fix the fracture in about half of the kids, about 50%, if they didn't have a pulse when they arrived, just by us fixing the bone, the pulse comes back. And again, even if the pulse doesn't come back right away, as long as the hand is pink and it has brisk capillary refill, then we can still observe those patients because the vast majority will regain their pulse eventually, and they have that rich collateral blood flow, as you can see, that network of blood vessels around the elbow that's still sufficient to support the arm. But we may observe that child for 24 or 48 hours in the hospital to make sure they're still doing okay and not showing any signs of increasing pain that could indicate some level of ischemia, or if they're developing signs or symptoms of a compartment syndrome. The patients who do not get a pulse back and have signs of ischemia, the hands white, pale, cold in the operating room, those are the patients that might need some type of vascular repair. But again, those are few and far between. When we look at our experience, and I'm going to kind of skip over some of this literature because you don't really need to know that, but when we look at our experience, we had like 500 operatively treated fractures over a 5-year period before I started here that we looked at. A good number of them did present without a pulse. But we didn't have any vascular repairs. Again, typically just realigning the bone, taking the pressure off of the vessel, and stabilizing things. As long as the hand has good perfusion, then I think that that is one good reason to either observe the patient or at least feel more confident that they're not going to be at risk for a long-term sequelae related to these injuries. But a third of them did have nerve injuries as well. Typically they resolve. So again, that's just something we follow up with. And you may start to see more of these patients become familiar of when a child's not moving certain fingers, and you can tell that they might actually have a nerve injury associated with these fractures. But we don't expect you to know all the nerves and all the examination things, but I expect that a lot of nurses start to just pick that up from their experiences. You can also get compartment syndrome with these injuries. It's pretty rare. In our experience, it was less than 1%, but certainly we have had to take patients to the operating room for the development of a compartment syndrome because there is so much swelling in the elbow that can progress into the forearm. But the vast majority of these kids really will do well, even if they look terrible and nasty at the beginning. And fracture reduction alone and careful observation is typically all they need to get these kids back in the game. Okay, we're on to the last part. Is everybody good? Nobody's falling asleep yet? Okay. All right, sorry if I'm going too fast, but this is all important stuff. So if there's anything else to take away from this talk, it's sort of warning signs and being able to identify a compartment syndrome. Again, you'll probably all encounter it maybe or have a patient that could be concerning for the development of it. So it is important to know what patients are at risk and how you pick it up. This can be any patient really that has a fracture. Our most common ones would be tibia fractures. Higher energy, you think a little bit higher risk, but even if the fracture doesn't look that bad, if it's a high energy, there's much more chance that there could be some more muscle contusion or involvement, and there still could be a lot of swelling. So higher energy, regardless of how nasty or simple the fracture looks, can be at risk. Obviously, if there's some sort of crush injury, the leg was rolled over by a truck, that's going to be a little bit more worrisome. If the patient has some sort of bleeding disorder, anytime there can be more bleeding after a fracture that goes into the muscle that causes some compression. And then we also see some other things that are not necessarily related to orthopedic injuries, but we see them after IV infiltrations or even in neonates after birth. So regardless of where you're going to be working, I think there could be a potential that you'll have a patient that could be at risk for a compartment syndrome. So has anybody seen a patient with a compartment syndrome or a patient that has been treated for one? Okay, good. So maybe I will teach you something. So what is a compartment syndrome? It basically is increased pressure within the muscle. If you look at that picture, it's like looking at like a cross section of a leg or an arm, basically. So the muscle is all surrounded by a lining called fascia. And the muscles are sort of grouped together. We'll review this in a little bit more detail in a minute. And they all have a lining, kind of like the casing on a hot dog. And if that muscle gets significantly swollen, then the blood flow to that muscle becomes difficult. It becomes harder for the blood flow to get into the muscle because there's so much pressure built up into the muscle. And obviously, when the blood can't get into the muscle can't get its nutrients, it can't get the oxygen. And the same thing happens to the nerves as well that help make that muscle function. It is a surgical emergency in order to avoid permanent muscle damage and loss. So at some point, when you have a patient that has a developing compartment syndrome, the muscle injury goes from something that's reversible, we can treat it and we can keep the muscle healthy and functioning, to an irreversible. And we never want to get to that point where we've missed it and now the muscle damage is irreversible. Even surgical treatment can't make that function better. So again, this is what a compartment looks like. So we've got groups of muscles. There's also a nerve and a blood vessel that will run with those muscles. And then the muscle has the lining called the fascia. So that green perimeter is, for example, of a posterior compartment in a leg, but we'll look at this a little bit more closely. So in the lower leg, the muscles are actually grouped into 4 different compartments. And why is this kind of important for you to know is because the compartments are responsible for different movements. And so if you're examining somebody or if you have an order to do neurovascular checks on a patient, it's really important to know a little bit about what you're looking for. Again, not that we expect you to know the names of the nerves and things, but there's some simple things that we can teach you so that hopefully you can pick up if there's a change in exam or a worrisome finding, something new that wasn't there before that you can alert orthopedics right away. And every year, believe me, we have nurses who pick up compartment syndrome on the floor. And if it wasn't for our nurses, sometimes we might not know because you're monitoring and you're checking on the patients a lot more frequently than we're able to. So we really do rely on the team effort and making sure that we identify this properly so that we can treat it emergently. So the first compartment we'll talk about in the lower leg is the anterior compartment. Obviously, that's the muscle groups that runs across the front of the lower leg, the shin, if you want to call it. It's responsible for what we call dorsiflexion, so that's lifting the ankle or lifting the foot up towards the sky, and toe extension, same thing, lifting the toes up. It's very important to sort of assess that from a neutral position, because if you ask somebody to just wiggle their toes, kids are very good about just kind of bending their toes down, and then sometimes you can see them rebound up to a neutral position, so you think they're moving their toes up and down, but really you want to have them rest into a neutral position and ask them to lift their foot or their toes up to the sky or towards their nose. And that way you can confirm that, yes, they have that function, which is the anterior compartment function. The sensation is right between the web space of the first and the second toe. So if a patient starts to get numbness right in that first and second web spacer, or that first web space, then that could be an early sign that there's something squeezing on the nerve in that anterior compartment. So that is also important to know. The lateral compartment is on the side of the leg, the outside part of the leg towards the small toe. Those muscle groups are responsible for what we call eversion. So that's that picture demonstrating there where the small toe is moving out towards the side. The sensation in that muscle group is the top of the foot. So that's the second area you want to test on the foot to see if the child is complaining of any numbness. That could indicate that the nerve is getting squeezed. So you've got the anterior compartment does between the first and the second toe. The lateral compartment does the top of the foot. And then the posterior compartment is responsible for the opposite ankle motion, plantar flexion, which is pointing the foot down like a ballerina, curling the toes down, which is called toe flexion. And the sensation for the posterior compartment, which is the back of the leg, the calf muscles, if you will, is the plantar aspect of the foot. So it's a totally different nerve. So if any of those muscle groups or movements become weak, or if a child becomes numb in any particular area of the foot, that's giving us clues about what area might be developing a compartment syndrome from swelling that's not only squeezing the muscle and not giving the blood flow there, but also affecting the nerve. The forearm, the main compartments of the forearm are what we call the volar compartment here on the front of the forearm and the dorsal compartment on the back of the forearm. And there are different groups of muscles that are a little bit deeper than others. But in general, the volar compartment is going to give you wrist flexion, so bending the wrist down, making a fist, also flexing the thumb. So the front muscles here do this, so think fist. They're innervated by 2 different nerves. So if you're going to check sensation on a hand, it's the index finger The palmar aspect of the index finger gives you the median nerve. You want to check the small finger, same thing, palmar aspect of the small finger, that gives you an ulnar nerve. Two different nerves that you're checking to make sure the child isn't complaining of any numbness. And kids are tough. They may not know what numbness means, but you can always compare it to their normal hand and say, does this feel normal? Does it feel like your other hand when I touch it here? And then sometimes they get it and they'll say, no, it feels funny, or I can't feel it, or it's different. So it's important to kind of sometimes get that information from the children. And then the last compartment in the forearm is the dorsal compartment. So the back of the forearm, that's going to do what we call wrist extension and finger extension. So lifting the thumb up, lifting the fingers up, and then extending the wrist. And that sensation is on the back of the hand. So if you're going to check and do a compartment check or a neurovascular check on a hand, you're going to do index, small, and then something on the back of the hand. And that gets you the three main nerves in the forearm that could potentially be injured by a compartment syndrome. So what can you all do? Just recognize it. Again, you don't have to remember all of this, but we'll teach you some other warning signs as well. But the eyes don't see what the mind doesn't know, right? So you have to have a little bit of information or background so that you can be ready to pick this up if you have a patient that is worrisome. Like I said, the exams can be very difficult in kids. In your training, you may have learned the 5 Ps which is what we use kind of in adults, which are pain, pallor, like coolness, pulselessness, which is a very late stage warning sign of a compartment syndrome, paresthesias, or pain with passive stretch. You start moving the ankle and they're jumping off the table at you because that muscle is so painful. Those are less reliable in children, so we don't teach the 5 Ps so much in children. The single most sensitive indicator that a child is developing a compartment syndrome is an increased need for pain medication. So if they are you're giving them medication, they're not responding, you're giving higher doses, you're giving more frequent doses, you're giving IV instead of orals, that is sort of a cue to consult orthopedics so that we're aware that, hey, this child, something's wrong. Like they're needing more and more pain medication. Nothing we do seems to be making this child comfortable. Swelling or pain, again, that does not resolve with the pain medications, and elevating. So you got to do everything that you can. You're elevating the extremity, you're giving them pain medications, and this child seems to still be like off the wall, off the charts in pain. Or if there's some sort of change in the neurovascular examination. So the child starts complaining of numbness, or they can no longer move their toes, move their ankle, or move their fingers like they were before. Those are all sort of things. And some children present a little bit atypically. You know, we had a compartment syndrome not that long ago where the child had pain scores of 2, and he had a raging compartment syndrome with dead muscle. But, there's language barriers. There's all sorts of reasons why a child might not be an advocate for themselves or be afraid to say how much pain they're really in. But if you sort of were monitoring his exam, he kind of went from being able to move the foot to not being able to move the foot, and that's a bad warning sign as well. So be aware of what's most common indicator of a compartment syndrome, but know that some kids may not present normally, and the exam is also pretty important. So those are the 5 Ps that we talked about that are more kind of what we teach for the adult world and less reliable for kids. Increased pain is obviously the first one. Palpable firmness, so there will be firmness or tightness or a lot of swelling in the compartments when you touch it. Pain with passive motion, paresthesias, there can be some weakness. All these are sort of late findings, and if there's no pulse, then we're really into a late stage of a compartment syndrome. What we want to take home from this talk is the 3 A's. So this is a little bit more sensitive for kids. So we already talked about the number 1 sensitive indicator is the increased need for pain medication, increased anxiety, and agitation. So the 3 A's, that's your first tip-off that something's not right for the child. So make sure that you give somebody a call. So consult us. You can also make sure that the extremity is properly elevated. If possible, you can loosen Ace bandages, dressings, splints, and then maintaining the blood pressure, because there's a perfusion gradient, right? If the blood pressure is low to begin with and the pressure in the compartment is rising, then that blood pressure is not enough to combat that increasing pressure in the compartment. So if a child is hypoperfused or really has got a low blood pressure, then doing something fluid or whatever the doctor is ordering to get the blood pressure back up. So the diastolic pressure minus the compartment pressure, if those things are within 30 millimeters of each other. That's sort of the diagnostic indicator for a compartment syndrome. So we have a little device, it's pictured here, it's called a striker device, where we can actually measure the pressure in the compartment, and then we can compare that to the diastolic blood pressure, so we can know if there's an indication to surgically release that compartment or not. You obviously are not going to be doing that, and typically I say that compartment syndrome is a clinical diagnosis anyway. If a child has all the warning signs that a compartment syndrome is impending, then we don't even need to do the measurement of the pressure. However, if we have a patient that's intubated and sedated in the unit and is high risk and that we're monitoring, then sometimes the pressure is the only way that we really know if there's something going on there that needs to be treated immediately to avoid muscle damage. So we use that in conjunction with the clinical exam, but we act on the clinical examination, not a number necessarily. What we do is something called surgical fasciotomy. So we're releasing that fascia, that casing around the muscle, so that the muscle has room to breathe. They typically require very large, extensive incisions so that we can completely decompress the whole fascia along the muscle compartment. In the lower leg, typically we do that through 2 incisions. So I think I have a picture somewhere. Whoops. Look at that, we're done. So these are pretty extensive incisions. You can see how swollen that leg is. We open up the fascia, and sometimes that muscle just bursts. They're almost like popped out of that fascia. We never want to see this, so this is actually an example of some ischemia. So that muscle is black. It doesn't look super healthy, and so that muscle has already had some permanent damage from the compartment syndrome. But oftentimes what we like to see is that muscle may be a little pale when we first open it up, and then it becomes more pink like the second that we open up the fascia. Then the wounds are generally left open for a period of time to let the edema and all of the swelling calm down. And then usually wound vacs are how we're going to be treating these large open wounds. And then hopefully, with luck, if the edema goes down, we can go back and repair the wounds. Other times they require skin grafting if it's really extensive. But again, the key is detection, early detection. We can treat it, and then we can avoid muscle loss. And you guys are our eyes and our ears, so you are all super important members of this team to make sure we're always doing the right thing. And always assume a full recovery for children. Children are just absolute miracles, and so we always like to do everything that we can, because even the worst of injuries, they will bounce back, and they're generally pretty motivated. All right, you all. Happy Friday. Hopefully we stuck on time. Any questions for me? Go ahead.
What percentage of these kids most likely get amputated?
From a compartment syndrome? Yeah, I mean, I can't really give you a number. I mean, I think the key is whether or not there is muscle necrosis. And if the muscle is dead, it needs to be debrided. It needs to be removed. But even if there's some loss of muscle, so even if we open it up and there's some muscle that's viable and we can clean out the unhealthy muscle, generally we do everything that we can, and we don't go on to amputations, everything that you can to preserve the leg. I mean, it really just depends on the circumstance for sure and how much muscle loss there is. If there's an infection that's going along with it, obviously if you have a lot of dead tissue, big open wounds, then there can be an infection risk. So, we can't sort of classify this into one thing, because there's lots of different reasons why a patient may have a compartment syndrome. But if it's an injury and we've treated it, and kids, like I said, I don't want to say they're salamanders, but their potential for recovery is unbelievable. I had a patient who I debrided, he lost about half of the whole anterior compartment muscle. And a year later, he's got almost full strength back in his foot when he had nothing, like zero function for many, many months. And it just slowly came back. So the muscle that was left that was healthy kind of takes over, and he just gradually became stronger. He plays basketball. He doesn't need a brace. So always assume a full recovery. But just because we have to take somebody to the operating room for a compartment syndrome does not mean it's going to be a bad result for sure. But the idea is that we catch it before the muscle gets to that ischemic state for sure. So it is very time sensitive. Anything else? Awesome. You all have a great weekend. Thanks so much for your attention.